Hello everyone and welcome to our module on adrenergic antagonists. In this module, we're talking about adrenergic antagonists. We'll talk about everything we need to know about the drugs under this class with respect to classifications, examples of the drugs, the mechanism of action of the different classes, indication or uses of the drugs, adverse effects, and some contraindications. In the previous module on adrenergic agonists, we made mention of the fact that drugs classified as adrenergic agonists are drugs that tend to mimic the action of norepinephrine. Now, in the case of adrenergic antagonists, these are drugs that tend to oppose the action of norepinephrine, and in doing so, they tend to work at different adrenergic receptor sites in the body. If you remember from our module on the introduction to ANS pharmacology, most of the adrenergic receptors are going to be found on effector organs supplied by the sympathetic nervous system. So, because adrenergic antagonists tend to block these receptors, we tend to refer to adrenergic antagonists as sympatholytic drugs because they tend to block the sympathetic nervous system eventually. How do we classify adrenergic antagonists? We classify them based on the type of receptors that they are working on. Remember that we have two types of adrenergic receptors, the alpha receptors and the beta receptors. So the sympatholytic agent or the adrenergic antagonist could be classified as either an alpha blocker. These are drugs that work on alpha receptors exclusively, beta blockers, which are drugs that work on beta receptors exclusively, or what we call mixed blockers, which are working on both alpha and beta receptors. Each of the different blockers, the alpha and beta blockers, are further sub-classified into selective and non-selective drugs. Remember that alpha blockers, alpha receptors are divided into alpha 1 and alpha 2, and beta receptors also tend to have different types. You have beta 1, beta 2, and beta 3. So drugs could either be selective or non-selective to either of these the examples of the alpha or beta receptors. Now, this is an image that depicts for us the classification of adrenergic receptor antagonists with a number of examples under each of the subclasses. I will be talking about the examples in the next couple of slides. Starting with the alpha blockers, we'll start with the non-selective alpha blockers. So these are drugs that could either work on alpha 1 or alpha 2 receptors. Drugs on this class would include phenoxybenzamine, phentolamine, egotamine, and talazoline. And very important to note, phenoxybenzamine and phentolamine tend to be separated in the sense that phenoxybenzamine tends to be classified as an irreversible alpha blocker, whereas phentolamine is classified as a reversible alpha blocker. So please, it's very important to note this for your income because they love to test on differences between these two drugs. For the selective alpha blockers, starting with alpha 1 selective drugs, we have a subgroup of alpha 1 selective drugs classified as quinazolines. So quinazolines include drugs like prazosin, doxazosin, caramzosin, tamsulosin, and tarazosin. If you pay attention, you will notice that most of those drugs that are classified as the quinazolines tend to end with the suffix azosine in their name somewhere. So we have prazosin ending with azosine. We have doxazosin also ending with an azosine. We have some exceptions to the rule like taramzoline and tamsulosin, but most of the other drugs under this class usually tend to end with the suffix azosine. So if you see any drug ending with an azosine, you should be thinking about an alpha 1 selective drug. Other examples of alpha 1 selective drugs are the indoles, so drugs like indolamine and other drugs like trazodone and acetaminophen. And they could always test you on any of these drugs. So having a drug book and having a list of drugs written down would be helpful to remember each of these drugs, so they can test you on any of them. For the alpha 2 selective drugs, we have very few alpha 2 selective drugs, drugs like yohimbines, indazoxans, and atipamezole. These are examples of alpha 2 selective drugs. They are not commonly drugs that we tend to use. Most of the time, yohimbine is used, as you can see in the picture below, to improve body composition or in fat burning. Moving on to the beta blockers, we start with the non-selective beta blockers. Non-selective beta blockers are very importantly divided into two subclasses. So we have the partial agonist and the partial antagonist. You might be wondering, why exactly do we have the partial agonist as an example of a beta blocker. And the reason is because partial agonists tend to stimulate receptors, but they do so submaximally. And because they do so submaximally, they are indirectly inhibiting the action or activity of the natural ligand that would have done a better job, that would have done a maximal stimulation on the receptors. So we tend to refer to partial agonists as antagonists to full agonists, and that's why they are classified under beta blockers. So drugs like pindolol, oxyprenolol, and alpranolol are examples of partial agonists you should know about. And for full agonists, we have drugs like propranolol. Propranolol tends to be the prototypical drug for beta blockers. So always remember propranolol, and it's depicted here in this image. Aside propranolol, other full antagonists include drugs like sotalol, timolol, and nadolol. What you quickly notice about most of these drugs are they tend to most of the drugs classified as beta blockers tend to start with the letters N all the way down to Z. And that's one way to remember them. The only exception to that rule is drug alpranolol. So remember, alpranolol does not follow that rule. As you will see for the selective drugs, you will notice that most of the selective drugs tend to start with letters starting from A and ending at M, with some few exceptions. We'll mention that when we get to that stage. Selective beta blockers, starting with the beta 1 selective drugs, we have drugs like acebutolol, atenolol, bisoprolol, betaxolol, ciloprolol, esmolol, metoprolol, and nebivolol. And you quickly notice that most of these drugs usually that start with the letters A all the way down to the letter N and to letter M. The exception to this rule there is nebivolol. Nebivolol is the only one starting with a letter beyond M. If you remember that the non-selective drugs, whether partial agonist or the full antagonist, tend to start with letters ranging from N all the way down to Z, with the exception of our alpranolol. And it's just one easy way to remember the drugs, whether they are beta 1 selective or non-selective. Another very important thing about our beta blockers is the fact that all beta blockers tend to end with the suffix LOL, lol. So think about laughing out loud, think about beta blockers. And this is one way to also remember the fact that any drug ending with the LOL or LOL is likely classified as a beta blocker. For the beta 2 selective drugs, we have the drug butoxamine. This is not a very commonly used drug. It's a drug that we tend to see for research and laboratory purposes, but it's one that you need to notice is usually the only drug in the class that is worthy of note. Then finally, we have the mixed antagonists. The mixed antagonists are drugs that tend to either work on alpha or beta receptors. They're not really restricted to one of those receptors. So drugs like avidilol, labetalol, bocidolol, and medroxalol. Worthy of note is carvedilol and labetalol. These are commonly used drugs. Labetalol tends to be used for treating hypertensive emergency. That's when someone is having hypertension beyond 200 or 180 systolic and about 120 diastolic. Carvedilol is typically prescribed for pregnant women with hypertension, and that's one important indication of carvedilol. We'll talk about the other indications of our adrenergic antagonist when we get to the aspect of uses. Mechanism of action of the adrenergic antagonists tend to differ when talking about alpha blockers and beta blockers. Alpha blockers would be working exclusively on alpha receptors. So they bind on these receptors and then they block the receptors. And in blocking the receptors, they will prevent the natural ligand of the receptors, which is norepinephrine, from acting on those receptors. Remember that antagonists do not cause any conformational change of receptors. What antagonists tend to do is that they tend to sit on the receptor site and prevent natural or indigenous ligand from acting on those receptor sites. In the case of the non-selective blockers, this would bind and block on either alpha 1 or alpha 2 receptors. In the case of selective blockers, they'll be working exclusively on either alpha 1 or alpha 2 and not both of them. And this is a picture depicting for us the activity of our alpha blockers. You can see alpha blockers just sitting on the alpha receptors and preventing norepinephrine from acting on those receptors. As you can see, the alpha blockers is depicted by the black circle or oval shaped structure in the image. The beta blockers are very synonymous action with the alpha blockers in the sense that the drugs just sit on the receptors. The difference is that in the case of beta blockers, the receptors here are the beta receptors, either beta 1, beta 2, beta 3 receptors. So they sit on these receptors, bind on the receptors, block the receptors, and prevent the endogenous ligand, which is norepinephrine, from acting on those receptors. And we have non-selective and selective blockers. Non-selective blockers could act on all the beta receptors, beta 1, 2, 3, right? Whereas the selective blockers could either act on beta 1, beta 2, and beta 3. We don't really have beta 3 blockers on the other hand, but we do have beta 1 and beta 2 blockers that would act on either of them, but not both at the same time. And this is an image showing us the activity of the beta blocker. You can see the beta blocker represented by the blue dot or blue circle in this image. Beta blockers will be sitting on the beta receptors and just occupying the space. And what happens is that they will prevent the um, natural ligand, which is adrenaline or not norepinephrine, from acting on those at that site. And this is how they tend to perform their action of antagonism. Very quickly, this image is an image that tends to depict for us the difference between a full antagonist and a partial agonist. And what we would notice is that on the first part of the image, you have a receptor site that has no antagonist present, but the natural ligand, which is a catecholamine, acting there. And what we see at the end of the day is full stimulation, 100% stimulation of the receptors. The next, or in the middle of the image, you will notice that there is a beta blocker present at the receptor site. And on this particular image, you could notice that the natural ligand is not able to act on the receptor. You can see the natural ligand represented here in black. So they are being inhibited from working on the receptor site. But the effect we see is that we see no effect at all, because the beta blockers, or the beta blockers in this case, are just occupying the space and they are preventing the natural ligand from stimulating the receptors. Then finally, at the extreme of the image, you could see beta blocker with partial agonist effect. So these are the partial agonists, drugs like Pindolol, examples under this list. So a drug like that would act on the receptor and cause a weak stimulation. So the key word here is weak stimulation or partial stimulation. Because they are preventing the activity of the natural ligand, we tend to classify beta blockers that have partial agonist effect um, as adrenergic antagonists at the end of the day. The mechanism of action of the mixed blockers is not different at all from the ones for the alpha and beta blockers, in the sense that the mixed blockers tend to work on both alpha and beta adrenergic receptors. So they block those receptors and prevent the natural ligand from working on either of the receptors. What are the uses of our various adrenergic antagonists? Starting with the alpha blockers. Alpha blockers are used for three major conditions. First is hypertension. So we tend to treat hypertension using alpha blockers, particularly the non-selective alpha blockers like the phenoxybenzamines and the phentolamines. Other conditions we can use alpha blockers to treat would be a condition called benign prostatic hyperplasia, which is a form of condition we see in the prostate where we have increased growth of prostatic tissues, leading to obstruction of the urethra that passes through it. And then the last condition we use alpha blockers in treating is called pheochromocytoma, which is a tumor of the adrenal medulla. This is a picture of a benign prostatic hyperplasia, and in benign prostatic hyperplasia, what you notice is that there's an enlargement of the tissue of the prostate gland, and this enlargement will lead to obstruction of the urethra passing through it. One way we can relieve this obstruction is by giving a beta blocker. Beta blockers will relax the muscular part of the prostate, and in relaxation of the muscular part of the prostate, we have the urethra being opened up once more, dilated once more for urine to be able to pass through. And this is how we use the alpha blockers in treating benign prostatic hyperplasia. Please, it's important to note that it is alpha blockers we use in treating this condition. So drugs like prazosin, tamsulosin are the drugs prescribed for benign prostatic hyperplasia. So this is an image showing us the condition called pheochromocytoma. Pheochromocytoma is a tumor, as a malignant tumor of the adrenal medulla. The adrenal medulla is the part of the medulla that produces catecholamines. So what tends to happen in this condition is that we have a tumor producing excess amount of catecholamines, excess amount of epinephrine and norepinephrine. As a result, what happens is that the excess amount of epinephrine and norepinephrine will lead to excessive stimulation of the sympathetic nervous system. But what way to block or prevent or treat this condition than giving a sympatholytic agent? So sympatholytic agents like the alpha blockers would work perfectly for this condition. Also, beta blockers could also be used in treating pheochromocytoma, but we prefer to give alpha blockers just because of the effect or the symptoms we see, especially in relation to the blood vessels. So blockade of the sympatholytic with sympatholytic agents, blockade of epinephrine and norepinephrine activity by the beta blockers and alpha blockers will be useful in treating symptoms of pheochromocytoma, as we'll see. For the beta blockers, indications include conditions like arrhythmias. So beta blockers are usually classified as class 2 antiarrhythmic agents. We'll talk about that when we get to the cardiopharmacology session later on. Beta blockers will also be classified as an antihypertensive because we use it in treating hypertension. We use beta blockers like timolol in treating glaucoma. We could also use beta blockers like propranolol in treating conditions of ischemia like angina pectoris and myocardial infarction. We use beta blockers in treating hyperthyroidism because in hyperthyroidism we tend to see an increase in amount of sympathetic activity. So beta blockers would help in reducing those symptoms as a result. And we could also use beta blockers and alpha blockers as well in treating migraine. Remember the drug egotamine. Egotamine is an alpha blocker, non-selective alpha blocker that could be used in treating migraines. This is a picture of an arrhythmia. Like I said, beta blockers are classified as a class 2 antiarrhythmic agent. We'll talk about that when we get to the cardiopharmacology model. But it's important to note that the effect of beta blocker on the heart, particularly in beta 1 receptors, is the reduction in heart rate. And the reduction in heart rate is what we tend to make use of in treating arrhythmias. Remember that beta blockers are also classified as antihypertensive agents. How they perform the action of reducing hypertension of high blood pressure is by acting on the blood vessels and on the heart. On the blood vessels, beta blockers tend to block beta 2 receptors, and thereby they tend to reduce blood pressure, blood flow. Beta blockers also tend to act on the heart, beta 1 receptors on the heart, thereby they reduce heart rate and cardiac output, and as a result, reduce blood pressure. Very importantly, beta blockers also tend to work on beta 1 receptors. They block beta 1 receptors in the kidneys, and in doing so, they prevent the production of renin from the kidneys. Remember, renin is part of the renin-angiotensin-aldosterone system, and that system is there to increase blood pressure in the case of hypotension. So when you block renin production by blocking beta 1 receptors, you shut down the RAS system, and in doing so, you prevent the increase in blood pressure done by the RAS system. And this is one way in which beta blockers are very effective in reducing blood pressure and treating hypertension. This is a case of a woman that has hyperthyroidism, most likely due to Graves' disease. As you can see, Graves' disease is characterized by a symptom of hyperthyroidism with ophthalmoplegia. In this case, she's having proptosis, which is the symptom of ophthalmoplegia that she currently has. What we tend to see in Graves' disease and hyperthyroidism is an increase in sympathetic activity. So all the sympathetic nervous system will be stimulated and excessively done. So one way we can reduce symptoms would be to give a beta blocker that would numb all the symptoms of the sympathetic nervous system experienced by the patient. What are the side effects of the sympatholytic drugs? So side effects of alpha of the adrenergic antagonist includes conditions like orthostatic hypotension. Remember that we use beta blockers in treating hypertension. So the logical adverse effect would be a side effect of hypotension. Another side effect is bronchospasm. This is very important when we give especially the non-selective beta blockers to patients. So when we're giving non-selective beta blockers like Panolol to patients, it's always important to ask if this patient is asthmatic, because one of the symptoms of asthma is bronchoconstriction. So giving a non-selective beta blocker will lead to the blockage of beta 2 receptors in the lungs, and that can worsen the symptoms of asthma. So the reason why we have bronchospasm as an adverse effect is because of the blockade of beta 2 receptors in the lungs, which would lead to bronchoconstriction. Bradycardia is a side effect of beta blockers use because beta blockers tend to reduce the heart rate. As a result, they lead to bradycardia. Hypoglycemia is also a side effect. Remember that beta 1 receptors are found in the liver. So blockade of beta 1 receptors in the liver will lead to a shutdown of gluconeogenesis and glycogenolysis. And as a result, that will lead to a reduction in the glucose levels in the blood. Erectile dysfunction could also be a side effect. Remember that the sympathetic nervous system is there in the performance of the action of ejaculation alongside erection. Erection is done mostly by the parasympathetic nervous system, but ejaculation is done by sympathetic nervous system. But once we are blocking the sympathetic nervous system, this can affect the erection and ejaculation. The person could have problems with ejaculation and problems with erection as a result. Hyperlipidemia is also a side effect. We tend to see increase in lipid levels within the blood once we give beta blocker. Depression, dizziness, and lethargy are also side effects of beta blockers and alpha blockers. What are some of the contraindications for adrenergic antagonist. So contraindications of sympathetic agents include conditions like asthma. Remember that in asthma, the patient is already experiencing a bronchial constriction. So giving an adrenergic antagonist, especially a non-selective beta blocker, will lead to the blockade of beta 2 receptors in the lungs, and that will worsen the symptoms of asthma. Hypotension is also a contraindication. Remember that beta 1 blockers or even alpha blockers tend to be used for treating hypertension, not hypotension. So a patient that has hypotension will get their conditions being worsened once they are placed on any of the sympatholytic agents, either alpha blockers or beta blockers. And then finally, shock is a contraindication. Shock also tends to mirror hypotension, right? Once there's a shock present there, meaning the person is having reduction in blood flow across the blood vessels, we don't want to give them in either a beta blocker or alpha blocker because it will worsen their condition as a result. And that concludes our module on the adrenergic antagonist.